Hello, I'm Dr. Andy O'Shaughnessy, and today I want to talk about how to have a difficult conversation with patients and families, conversations regarding end-of-life issues. I don't have all the answers. I don't even have all the questions. But I do know dealing with patients, they have their own idiosyncrasies. Dealing with families, they have their own idiosyncrasies. Dealing with healthcare providers and myself, we have our own idiosyncrasies. We're dealing with the science of medicine, which is really more of an art than a science. We don't know a lot about the human body. We're dealing with probabilities, which is always difficult. And we're dealing in a financially broken healthcare system. All these variables create a very difficult situation to have a conversation with a family about death and dying. I don't have all the answers, but I do have a framework that I developed over the years to try to do a better job with having these charged conversations when we have so many variables and so many unknown. A framework is just a set of guiding principles that I use and that can be modified to have a good conversation about a bad issue, death and dying. So when doing the difficult conversation, it's important to understand the who, what, where, when, how, and why. But I've flipped it on its head a little bit, and I want to start with why. I often do this after I watch a TED Talk by Simon Sinek that says start with why. And what this talk was all about is if you're doing something difficult, a project, really anything in your life, if you start with why you're doing it in the first place, the other steps, the who, the what, the where, the when, they all fall in place if you really understand why. So, why am I passionate about talking about death and dying? Well, first of all, I love what I do. I've been doing this for almost 30 years and I still love every day of it. To not have this conversation regarding end of life with a patient or family has a very negative impact. It's been a bad day for me, for the patient, for the family, for everybody. To have a good discussion with patients about death and dying is a good day. You would think it would be the opposite. This is actually somewhat counterintuitive. To have a discussion with a patient about death and dying almost always is a very positive thing. The family at the end of the conversation is much more relaxed and appreciative that somebody took the time to lend credence to what they were seeing or to talk with them about their feelings. I'm not perfect, and there are times when I've not had this conversation when I know I should have. I'm busy, I'm doing rounds, a lot of things are happening. I know I should talk with the patient and family about end-of-life issues, but I don't do it. I'll think I'll do it tomorrow, or I'll let somebody else do it. Those are bad days. They're bad days for me, but they're also bad days for the family and for the patient. So I try not to do that. I strongly believe that suffering at the end of life is not necessary. Even though patients often do suffer at the end of life, I don't think it's necessary. I strongly believe that we in medicine have very good predictive powers. But I also strongly believe that we can be wrong. My predictive powers about death and dying are not perfect. They're good, they're not perfect, and there are times I will be wrong. And I really believe a much higher power has my back when I make mistakes. For instance, I've had conversations with patients and families and said, you probably shouldn't do dialysis. Your life expectancy is going to be measured in weeks to months. And I've had patients go 3 to 5 years. But I've also had conversations with families and patients we should consider dialysis. And turned around and 10 minutes later, they had passed away. So I'm not perfect. My predictive powers aren't perfect, but they're good. They're good enough that I'm willing to have these conversations with the patient and family. I do let them know that I don't have any predictive powers about when they're going to die. And I'll explain that further in a second, how I handle that. I consider to have the talk, and we kind of, in my practice, we call the talk. Patient will need the talk, or the family will need the talk. I really think the talk is the cure for modern medicine, because modern medicine can treat just about any disease today. But modern medicine can cure almost none of them. So let's start with why. Modern medicine has people living longer. But modern medicine has had a hard time making people live better. You're talking about quality of life versus quantity of life. Life expectancy is increasing. Length of life is not. It's still around 109, but more people are pushing that limit. The death rate hasn't changed much since 1954. It's still about 9 per 10,000 per year. About 30% of the U.S. Medicare budget is spent in the final 6 months of life. We have to do a better job in the final 6 months of life. Look at it this way. If you're dying in Miami, Florida, the last 6 months of your life very likely will look like this. You'll see a doctor about 46 times. Most of them will be specialists. You'll spend more than 6 days in intensive care unit and stand a 27% chance of dying in the ICU. The tab for all that will run just over $55,000. But spend the last 6 months in Portland, Oregon, and you'll go to a doctor about 18 times. Half of those visits will be with your primary care doctor. You'll spend, on average, 1 day in the intensive care unit and stand a 13% chance of dying in an ICU. You're likely to die at home with the support of a hospice program. The tab will be slightly more than $10,913. In both cases, the length of life was unchanged, but the quality of life and certainly the cost of care is much better in Portland, Oregon than Miami, Florida. Why is that? Well, the West Coast tends to be much more progressive about how they handle death and dying. They are much more adept at having these conversations, and they have a much stronger hospice and palliative care penetration on the West Coast than in the Deep South. In both cases, the length of life was unchanged. It is possible that something about less aggressive care certainly leads to a cheaper form of care, but it also may lead to a longer life under certain conditions and certain disease processes. With the why, we talk about good death. Good death is when you have pain and symptom management, clear decision making, you have preparation for death, completion of any tasks, contributions to others, and affirmation that the patient and the family are a whole unit. In bad death, it's really the opposite. You have needless pain and suffering, no decision making, a lot of family and social conflict and strife. Everyone feels loss of control. They feel like they're just giving up on life. So, who has this conversation? Well, I believe it's not just a physician that has it. I really believe anybody can have this conversation. And certainly everybody needs to be on the same page. The physicians, all of them. The nurses, all of them. Spiritual care providers, PT, OT, RT, nurses aides, social workers, dietitians, administrators. Everybody needs to be on the same page. Nothing is worse than if I go in and have a conversation about stopping dialysis or not starting dialysis or not doing this therapy or that therapy or getting hospice involved. And then to have the occupational therapist, for instance, come by and give the family false hope. Because they will cling to that hope like you would not believe. It really destroys what we're trying to do, which is provide a good death for the patient. And so it's important that everybody understand these concepts and to the best of their ability use these concepts to allow the patient to have a good and peaceful death. In other words, we need to speak in a unified voice. Many times patients and families talk about the frustration of being in the healthcare system and hearing conflicting information. I honestly do believe sometimes we do give conflicting information, but I believe many more times patients and families are hearing information and they're cherry picking what they hear and want to believe, and then they're calling it conflict. In reality, no one really conflicted what they said, but the family is twisting what they're hearing from some people and providing false hope and clinging to that. And I believe it's my job, it's our job to try to give them realistic expectations and keep driving down those false hopes. So the who also includes the patient, the family, the friends. Everybody needs to hear the story. The more people that hear the story, the better. So what is this conversation? Well, it's a no-holds-barred, direct, honest prediction about possible outcomes. The best I can formulate the plan, give them all the options, and most importantly, give a prognosis. We in medicine are very uncomfortable with prognosis. We're very uncomfortable with this whole concept of trying to predict because we're not very good at it. But I still believe I'm good enough to at least make a prognosis. I do hedge my bet a little bit, and I do tell them I could be wrong, but I'm going to give you a prognosis. I'm going to give you a time frame of what I believe. And again, using a table I have here, before I walk into the room, oftentimes in my world, I use this prognostic guide when I'm talking with families. Before I walk into the room, I take a quick look at this, if we're talking about dialysis, because this is very dialysis specific, about if you take a patient of a certain age, sex, and degree of frailty, how long they can expect to live on dialysis. At least that way I have some numbers to give them. When do you have the conversation? This is a little more difficult. When the team feels that there's a realistic assessment of possible outcomes that would include pain and suffering that would negatively impact their quality of life, it's time to have the conversation. The problem is that's a very fuzzy concept. We know when we see it. It's kind of like many years ago, the Supreme Court was asked to define pornography, and they basically could not come to a definition, but they could say, you know when you see it. Well, that's the way it is when it's time to have this conversation about death and dying with a patient. You know when you see it. We almost always err on the side of having this conversation too late and not too early. Hospice was designed for the last 6 months of life. But you know how long the average patient is in hospice in America? It's 4.5 days. Even though it was designed for 6 months, it is actually practiced for the last 4 or 5 days. Why is that? It's because we're afraid to have this conversation with families. We're not very good at it, and we wait way, way too long before we have this conversation. But also, having this conversation too early is not helpful either. I'm not a big advocate of DNR forms. Some states call them post forms. It's where you check a box of, do you want artificial food and hydration, or do you want chest compressions, or do you want to be put on artificial machines and a ventilator? And you do that while you're healthy. I think that's silly. It doesn't work. And the reason it doesn't work is I have an illustration here. If I'm talking to a group of 100 people, and I ask them, if you're 80 years old, blind, and diabetic, and then your kidneys failed, would you want to start dialysis? And almost universally, all of them say, no, they would not start dialysis. But you know what the data show? 80-year-old blind diabetics have about a 95% chance of starting dialysis when push comes to shove. In our world, we say there's no atheist in foxholes. What it means is when you're staring death in the eyes, often you'll do things you didn't think you would do when you were healthy. So to ask somebody when they're healthy, do you want dialysis at age 80, it doesn't work. Because we as humans, we don't know what we want until we know what we need. This conversation about death and dying needs to be happening much more proximate to the events at the time. It's when you're talking about starting dialysis or you're talking about stopping dialysis. That's when you have the conversation. Where to have this conversation. I have very strong feelings about this. The bedside is really the only place to have this conversation. That being said, you can do it in a quiet room. I've done that. You can do it over the phone. I have done that. I don't like to do it in those two places. They're often it's a poor conversation. It's hard to have this conversation over the phone. I've had this conversation when talking with an interpreter. It doesn't work very well, but sometimes you have to do that. It's not my first choice. The first choice is at the bedside. I've often wanted to write a book called Can We Talk in the Hall? Because this is a big problem. When you walk into the room and the family knows you're going to have this conversation about death and dying, oftentimes they'll say, can we talk in the hall? And the reason they do this is a very mistaken notion that somehow talking about death and dying with a patient actually speeds up their death process. It causes them to give up the will to live. And nothing can be further from the truth. The data show actually the opposite. By talking in the hall, you're actually telling the patient, we're not comfortable talking about this, so we're not going to talk in front of you. So when they say, can we talk in the hall, I try to say compassionately, but no, we really need to talk at the bedside, because this is very important that John, or whatever their name is, hears the story. What often happens, I see this and it breaks my heart, the patient knows the family doesn't want to talk about it, and most patients, they love their families. The last thing they want to do is make them uncomfortable. So when the family says, let's talk in the hall, what they're saying is, let's not talk around the patient. It just shuts down communication. The patient now can't communicate because they don't want to hurt their family, and communication stops. The one time in their life when we really have to have good, open, and honest communication is shut down because of this uncomfortable feeling. So it's my job to address this right up front and say, this is uncomfortable. I know it is. It's uncomfortable for me. It's uncomfortable for you. But it's really important that we all talk openly and honestly. And I keep using the word honest in front of the patient and the family because they do want us to be honest. And so when they say, can we talk in the hall, just remind them that I need to be honest with the patient. And usually that they do come along and say, yeah, you're right, or we'll talk here at the bedside. Because talking in front of the patient has never been shown to cause them to give up or to cause depression. It's actually the opposite. I really believe by not talking about the obvious, you shut down communication, and that leads to depression and isolation in the dying patient. The last thing you want to do. So, how do you have this conversation? The how. Well, we start in my institution by having the social worker and or the nurses start to get the family together about 24 hours before we have the conversation. We give them a call and say, can you all be at the bedside tomorrow at a certain time, so that we can all be there at the same time. Before I walk into the room, I do a quick review of the chart. I do make sure that I have all the diagnoses, all the providers are on the same page. I know the age of the patient. I know the spouse's name, the patient's occupation, the hometown, the first name. I want to be as specific as I can. And then I try to work those facts into the conversation to let the family know that I'm not some fly-by-night individual who has no idea who or what I'm talking about. For instance, if the patient is a mailman, I'll say, at some point in time during the conversation, boy, this must be really hard for somebody who's delivered mail and been so active their whole life, to now end up in this shape. It lets the family know that I know something personal about the patient. It provides a bonding between me, the patient, and the family. It's a technique that works really, really well. Also, you want to take one last look at the chart. The last thing you want to do is for me to go in and start talking about giving up dialysis or stopping dialysis or not starting dialysis or this treatment or that treatment, only to have somebody who came along after me that day, after my rounds, and wrote something in the chart about going for a CT scan or starting chemotherapy. Then there is conflicting information going to the family. So you want to make sure that I see the very last note in the chart before I walk into the room. I need, before I walk into the room, to have a very clear and concise expectation of what I want out of that conversation. I don't walk into the room and say, what do you want to do? Or what do you think about this? I walk into the room with the idea of I'm expecting to have them stop dialysis or to not choose dialysis or to not choose this. I really have an expectation of what I want so I don't sound wishy-washy. Then I walk in the room, I introduce myself and introduce my team. As best as possible, everyone should be sitting down. What you don't want to do, you don't want to be standing at the door with your arms crossed, talking, having these conversations. You really should be sitting down in as relaxed as possible to have this charged conversation. I actually, as the presenter, should be sitting at the head of the bed as close to the patient as possible, even if they're comatose. I have strong belief in this. It's okay to touch the patient, for me to hold the patient's hand or to touch their arm while we're talking. The reason I want to be sitting at the head of the bed by the patient is I want them, as I'm talking, I want the family to be looking across the patient at me. I don't want to be standing at the door having this conversation where they're all turned around, faced away from the patient. I want to make the patient the center of our discussion. And you do that by sitting by the patient and have them look at the patient as we're having this conversation, even if they're comatose. I personally do not ask the first question, how honest would you like me to be? I do have some partners that do that. I think that's a very acceptable question, but I just assume that they want me to be honest, and I start the conversation by saying, we're going to have a conversation. It's a difficult conversation for me to have, but we're going to have it as open and honest as we can. And I start with why again. I tell them, I value open and honest communication. We, our team, values the patient and you as the family, and We see families every day who are frustrated by poor communication and lack of information. I don't want that to happen here. I want this to be a very open and honest conversation. And I keep using the word honest because I want the family to focus on honesty because that's what it's all about. And then I start by stating the facts as best I know them at about a fourth grade level. I, for instance, will say, I know that John developed, lung cancer back in, 4 years ago, and that he went through 2 rounds of chemotherapy. And I kind of go through the facts, starting as distant as I can get that's still pertinent to the case. So again, I'm trying to get the family to know that I'm not talking about just what happened today. I'm talking about what this whole course has been, so the family can start to understand, this is not something that happened today. This is a course of events that led to today, but that I understand that course of events. And I do state, and I make sure of this, that all the providers are on the same page and agree. And if there's 1 or 2 providers that I have not talked with yet or are leaving, very cryptic notes in the chart, I actually will call them first and say, look, are you aware that I'm going to have this conversation, and are you okay with that? So that I'm honest when I say that all of us are on the same page. And then I present that this is a concept that I came up with years ago. What happened was I kept hearing families say, we want to do everything possible, just make sure they're comfortable. And it was very frustrating for me because I know that in medicine, most of the things we do are not comfortable. Nobody wakes up in the morning and says, I want to be comfortable today, take me to dialysis. No one wakes up and says, I want to be comfortable today, start chemotherapy. Most of what we do in medicine is discomforting, but we do it because we want longevity. Well, this concept kind of gets at the root of that falsehood that you can somehow do things comfortably yet aggressively. And so I came up with this idea of a fork in the road. And I tell the family, we're at a fork in the road. The one fork says we're going to do everything possible to keep them going. We don't care how uncomfortable it is. Comfort doesn't matter. What matters is longevity. And then I describe what that fork is, what that fork looks like, the best that I can. I say, dialysis, and I tell them what about dialysis and the transportation issues and sitting in a chair and what my patients feel on dialysis, what they feel after dialysis, or with chemotherapy, what they're going to feel. Again, it's a no holds barred, kind of a brutal conversation about what it means to be the aggressive approach. And then I talk about the length of that road as best I can. And again, I use that table or whatever prognosis I can get. I give them the best of my ability what I think that prognosis would be, how long length of life would be. And then I say, but there is another road. The other road is that everything we do, we ask the question, is this for comfort or for longevity? And if it's for longevity, we don't do it. If it's for comfort, we do it, because that road is all about comfort. Comfort trumps longevity. The one fork is longevity trumps comfort. The other road is comfort trumps longevity. And I discuss hospice and the how hospice works. Sometimes you'll hear the family say, wait a minute, we're talking about hospice? Because it's the first, when you use the word hospice, it's the first time that really drives the point home that we are talking about death and dying. And so when the family says, wait a minute, we're talking about hospice, is he dying? And the answer is yes. I don't beat around the bush. I don't say, well, there's always a chance, because they'll hang their hat on there's always a chance. So it's my job to, as brutally as I can, state what I believe to be the case. You can, and I do often say, but I hedge my bet. I could be wrong. And then I tell the family that in my belief system, we're not talking about death and dying anyways. In my belief system, we're talking about comfort versus discomfort. I don't believe we have been given the choice of death and of when somebody dies or when they live. That comes from a much higher power. We as physicians, you as family, the nurses as the nurse, we are given the choice of how much comfort versus discomfort are we willing to go through. But when it's time to die, that does not come from us. We don't get to choose that. And I tell them, I've been wrong before. I thought the life expectancy was going to be years, and it was minutes. And I thought life expectancy was going to be days to weeks, and it was years. So I stopped trying to predict when someone's going to die. This is about comfort versus discomfort. When they die is not our choice. And then I tell them the most important thing. You can't do both. You can't say, let's do everything possible to keep them going, just make sure they're comfortable. I can't do that. It's going to be one road or the other road. I keep it at a 6th grade level. It's cancer, it's not malignancy, it's death, it's not demise or passing away. It's complete kidney failure, it's not renal failure. I don't mention things like GFR, GN, or vasculitis. I keep it as simple as I can. It's high blood pressure, it's not hypertension. Lung failure. Failure is a very powerful word. It's a very honest word. And so I use that. We talk about it's a tube in the bladder, it's not a catheter. We have these terms in medicine that actually make things more confusing. Say nausea, vomiting, or hair loss. Don't say side effects or alopecia of chemotherapy. Make it as honest, but as brutal, but as honest as you can. At this point in time, I talk fast. I know that. And when I am nervous or excited or uncomfortable, I talk even faster, and I talk more. And that's a problem when you're having this death and dying discussion. Because at some point in time, I need to shut up and just be quiet and listen. So once I talk about the fork in the road, I just am quiet. And if I'm doing this in a live conversation, in a live audience, what I do is I'm quiet. I just stop talking, and while I'm not talking, I'm counting in my head up to 20. And when you're quiet for 20 seconds, boy, the tension in the room is palpable because silence is uncomfortable. We don't like silence. But at this point in time, it is so important for me as a person discussing this very charged topic of death and dying, it is important that I be quiet and just listen. Almost always, almost without a doubt, at around 10 to 15 seconds, somebody in the family will say something, and it resets the conversation. If I keep talking, once you drive home the point that we're talking about death and dying, and we're talking about this fork in the road, at that point in time, if I keep talking, their mind is off in Never Never Land. They're thinking about, they're dying and what's life going to be like without them and how are we going to pay the bills or whatever. They're not thinking about it anymore. But if I just shut my mouth and be quiet for 15, 20 seconds, one of them will talk. It starts the conversation all over again at a very, very basic level about what we need to discuss. It's amazing how this works, but it is uncomfortable to be quiet. You got to be careful what we say, because here's things that we typically say. Think of this as you're at a funeral and you're standing at the casket, and the surviving spouse is standing there. What do you say? Well, you say, everything will be all right. Or, what can I do to help? Or, God won't give you more than you can handle. Or, we'll get through this. Or, I'm sure things will get better. Or, I had a friend who had a friend who this, that, or the other thing. Those are trite, simple sayings that we say them because our parents said them. And our parents said them because their parents said them. But when you say those simple sayings, what you're saying is, I'm uncomfortable talking about this, so let's not talk about it. Instead, let's just rubber stamp it with this saying that we've all said when we're uncomfortable talking about it. And so you're shutting down communication by having these trite sayings. So I try not to do that. Instead, when you're communicating about during end of life, it's important to, first of all, listen. Even if it gets uncomfortable, as I just stated. It is okay to say, look, I don't know what to say. It's okay to acknowledge my shortcomings. It's okay to acknowledge the struggle the patient has been through. It's okay to say, look, talking about death and dying is uncomfortable for me as a physician, but I'm not going to let that stop me from having this conversation with you all because I believe it's important. Again, it lets the family know that I have some empathy, that I am human, that I'm not some ogre who is cold and callous and going to have this conversation about death and dying, that I do have feelings, and it is hard for me to do this because it's hard for them to do it too, and it allows them to now have empathy with me that we're on the same page. We're struggling with this, but we're going to struggle together. It's like a team. It's okay to ask, like, what are you afraid of? I ask the patient, with this problem of stopping dialysis, what are you afraid of? And then we'll discuss that. They basically say we're afraid of pain. Well, you can say that doesn't happen, or they say, I'm afraid my family's going to have to live without me. We can discuss that. And usually, when the family's there, it's a nice segue into a very powerful conversation that really needs to be held. You can ask about any uncompleted tasks, any family conflict. That's a tough one because in medicine, we don't usually like to get too much into family conflicts, and we shouldn't get too much into family conflicts. But at this point in the conversation, it's okay to just be aware, is there any conflict that is going to make this more difficult? If the patient's unable to participate in the conversation, then I ask, what would they want? And this is a very important point. I came up many years ago with my checkbook rule. I may need to change this rule because I realize now many people are not using checkbooks anymore. But I had this idea that if a patient can't balance a checkbook, if they don't have the mental wherewithal to balance a checkbook, we certainly should not ask them life and death decisions. I see this all the time. We're having this conversation, and one of the family members, the patient is nearly comatose, and they've got tube in their nose and or intubated, and they're just not clicking on all cylinders. And the family walks up and says, "You don't want to die, do you?" And the patient makes some sort of funny movement, very nondescript movement of their head, and the family says, "Well, see, they want to do everything possible." So I don't allow that to happen. I head it off at the pass and say, "Look, I don't feel that Jim, for instance. I don't feel that Jim has the mental wherewithal to understand or to participate in this conversation at the level that we need him to participate. Therefore, I need you to tell me what Jim would want." If Jim were able to step out of his body and look back on this situation, hear the conversation, what would he say? And I tell the family, I don't want to be crass, but I don't care what you think. But I'm legally, morally, and ethically required to care what Jim thinks. But I don't believe Jim can be part of this conversation right now. So therefore, you need to tell me what Jim would think. I ask, is there anybody else who needs to be involved in this conversation? Sometimes there'll be family members who are not there. I just need to be aware of that. Again, you're heading problems off at the pass. And I ask, is there any more questions at this point in time? I tell them what the rest of my day is going to look like, and I offer to be available. I leave my cell phone number. I do not force an answer. I think it's not right to sit there and say, I'm going to stand here until you give me an answer. It's too powerful of a conversation. There needs to be time where they can talk amongst themselves as a family, pray, do whatever they need to do. I offer them any resources that I may have. We can have the chaplain come by, or we can have social workers come by if they're not there. But I don't force the answer and say, look, you need to think about this. I'll be back, or you let me know, or let the nurses know what you think the best way to go is. And then I communicate with my nurses, the partners, and everybody else by leaving a note in the chart that is clear and concise so that we're all on the same page. You don't want to have this powerful conversation and then have the oncologist come in and say, we'll start chemotherapy after we've had this, not knowing that we had this conversation about not doing anything further. So make sure everybody is on the same page. Now, before everybody freaks out and says, wait a minute, you leave your cell phone number? Yes, I've been doing this for almost 30 years. I have never, ever run into a problem with somebody having my cell phone number. Occasionally, probably not very often, someone will call and say, look, we want to clarify this point or that point, or my sister was not part of that conversation. Can you discuss this with her? And I do that. It does not take very long to have a conversation over the phone. It's never been a problem, and I will continue to do so. Now, let's talk about this no hope idea. And here was a study my brother doesn't like. My brother's a cardiologist, and he doesn't like this study because what it shows is that if you take people, this was stage 4 congestive heart failure, which is fairly end-stage congestive heart failure, if you put them in hospice, they actually live longer. Not only were they cheap, this study was actually to look at the cost of hospice care versus aggressive care. It found out that hospice care is cheaper than aggressive care, but it also found out in certain disease processes, such as heart failure, you can actually live longer with hospice than with aggressive treatment. Something about active treatment for certain disease processes may actually shorten life. We may be kidding ourselves that dialysis in some patients lengthens their life. It actually may shorten their life, whereas hospice would have lengthened their life. Now I want to talk real briefly about communicating with difficult patients, difficult families. Occasionally you'll have a denying patient. That's really, really rare. Again, I really believe as we are dying, we usually know it. Something's going on in our body that we're aware of it, and they know it. And again, that's why you do not want to shut down any conversation with them, because they're feeling something's going on. And that's why that when you actually open the door and have this conversation, they are much more relaxed because you're willing to address their fears. The denying family, now that's much more common. That's probably the most common problem, is the family may be denying. So I address this right up front by saying, look, I don't know you, to the family, because I don't know most of them. I'll say, but I've been doing this long enough that I know most families would say I would do anything for my loved one. But what most families won't do is they won't allow their loved one to die peacefully. I say, look, at some point in time, Jim is going to die. He's got a lot of disease process. He's really far along the process. At some point, he's going to die. And when he dies, it's going to hurt. I'm sorry. God has designed it that way. I don't know why, but when our loved ones die, we hurt. Sometimes we as family members try to delay our hurt by having our loved one go through the pain and suffering. At some point in time, if you believe like I do that Jim is coming to the end of life, then we need to do the compassionate thing and take the pain away from him. It's going to hurt us, but it's going to hurt him less. Then you'll hear things like, he or she is a fighter. Well, the answer to that is, when they say that, is I say, look, I understand that. But at some point in time, the family has to take the fight on so that Jim does not have to fight anymore. It's the compassionate thing to do. Or they may say, he was told 10 years ago he was going to die, and now look, here we are, 10 years later, and you're telling me he's going to die this time. And the answer to that is that, look, every day is different. He is not the same person he was 10 years ago, or 5 years ago, or even 5 months ago, or 5 weeks ago. The disease he has is progressive, and at some point in time we have to come to grips with that he's no longer what he was 10 years ago. Or they may say, his or her mother lived to be 101. The answer to that is, no study has ever shown a genetic link to how long we will live on this earth. It just doesn't work that way. We all like to think that, but it doesn't work. The numbers don't hold out. When they say it's in God's hands. And I say, I agree with you. That's why in my belief system, we're not talking about death and dying. We're talking about comfort versus discomfort. I believe when somebody dies, it's not my decision, it's not your decision. It comes from a much higher power. But we are given, I think, the ability to choose comfort versus discomfort. So that's what I'm asking. How much discomfort versus comfort are we willing to go through here? They may say, well, we can't just pull the plug or starve him. And the answer to that is, again, I don't see it as starving. God has designed a way that when we can no longer handle food and nourishment, that we stop wanting food and nourishment. It's a very natural way to go. Now, we can override that because we think we know more than we do, and we can, and I use terms like shove a tube down their nose in order to feed them into their stomach, or we can shove IVs in their arm in order to hydrate them. But it's really more for us so we feel comfortable than it is for them, because let me tell you, they do not need they do not need these treatments in order to be comfortable. If there's family conflict, I've already mentioned that. Other than being aware of it, do not go there. You cannot solve family conflict, nor should you even get involved in family conflict at this point in time. When you're talking about death and dying with somebody, it really brings out the ghost in the closet. A lot of times families do have strife. They'll have one sister who's been doing all the work, and the other sister has been not doing anything, and all of a sudden there's strife between them, and they try to get you as the physician involved. And they often will try to use that conflict to diffuse the situation and really switch gears and talk about the conflict instead of about the patient. And so it's my job to refocus back on what we're talking about, let the conflict go. Acknowledge it, but say we're really here to talk about Jim and the dying process and what we want that to look like. Oftentimes, though, the ghost in the closet will be there must be someone to blame. Is that the family's frustrated by this point in time. Usually they've been dealing in the healthcare system for months, and they're convinced, or somebody in the family is convinced, that somebody made a mistake and we're going to get to the bottom of that mistake, whether it be a lawsuit or whatever. Again, don't go there. Address it, but don't try to belittle their concerns. Don't try to work through their concerns. Again, refocus on the patient. Keep the focus on the patient and the dying process. Let everything else go. Don't try to defend anybody. Don't throw anyone under the bus. If they're blaming another doctor, don't fall for that. Don't throw that doctor under the bus. Just let it go and focus back on the patient. The abusive patient, unfortunately, is not very common. The abusive family is much more common. The abusive family is again, they're upset, and sometimes when people are upset, they strike out. And again, I have broad enough shoulders, you need to have broad enough shoulders to accept that abuse and move on. Again, keep refocusing back on the patient. Sometimes there's a need to understand, and I call it the engineer. Sometimes there's an engineer in the family, and he just needs to understand this whole process. We're convinced that if we do an Excel spreadsheet and we, chart every blood pressure, or we, chart how much fluid's going in and how much fluid's coming out, and we do all these things, we can actually change the outcome. To them, when I hear that, I start to say, okay, he's probably an engineer. Then you got to start to say, the human body is very difficult. It is not a machine. It doesn't act like a machine. It has all kinds of variables that we don't understand. And so I try to put that idea away by saying that this is not a machine. The need to control, and this would be the lawyer. Or I've often noticed this in clergy. They, if you're a minister or you're a lawyer, they've always been in control their whole life. A lawyer can talk themselves out of any situation. And when there's a lawyer in the family, they're convinced that they can probably talk their way out of this whole dying process for right now. And again, you just need to address it in a compassionate yet firm manner that this is the facts as I know them. I could be wrong. I'm okay with that. I don't think I am. And we're going to have this conversation, and we need a solution. And so kind of shut the lawyer off from being able to talk too much. Or the need to treat. This is, I would say, the nurse. Nurses their whole life have been treating patients, and at some point in time, when there's a nurse in the family, they're convinced that if we do this, that, or the other thing, that we can change the outcome. I don't think it works. But, there's a little trick in hospice that if there is a family member who's doing this, is to give them a task. If there's a nurse in the family and they're convinced that if we do, the right thing, if we treat this or we do that we can change the course, well, then give them a task. Tell them, we need to have the urine output measured, even though we don't. We need to have the urine output measured every 4 hours, or the blood pressure checked, 6 times a day or whatever. As long as it doesn't hurt the patient, it gives that caregiver who their whole life has been doing these caregiving procedures, gives them something to do so they feel like they're giving back. It's a neat little trick. Sometimes you have the you can't give up syndrome. And we call this the niece from California. So I don't know why it is, but it seems like there's always a niece in California who flies in at the 11th hour after everybody else has seen what's going on. See, the problem is when somebody has this death and dying process, usually family members have seen it for the last months to years. The whole decline, the weight loss, the lack of energy, all the problems. They have seen it, and they're on board with, yes, it is time to switch gears. But then you have somebody who has not been proximate to that whole process fly in at the 11th hour and say, wait a minute, you can't just give up or pull the plug or have all these euphemistic terms and then fly away. and they don't realize what havoc they just wreaked. So that's where you head it off at the pass by saying, is there anybody else who's not in this conversation? And then I say, is there anybody who is not going to agree? So if the family's all saying, yeah, we agree with this, we think that comfort's the right way to go. Ask the question, is there anybody who would not agree with this? So that you can start the process of, do they need to talk to them, or do I need to talk to them, so that we're all on the same page. And then again, if we talk about dying, they'll just give up, and that's where we're not going to do that. So, thank you. Thank you.